Medscape published a commentary by Dr. Mandrola titled Expired Post-Myocardial Infarction Beta-Blockers Reduce Myocardial Infarction, stating that beta-blockers are losing their clinical value in the so-called post-reperfusion era. This viewpoint is based on the results of the REDUCE-SWEDEHEART Registry study. The New England Journal of Medicine published the results of the clinical trial evaluation of decreased usage of beta-blockers after myocardial infarction in the SWEDEHEART Registry, REDUCE-SWEDEHEART. They showed that disease outcomes were marginally better in the beta-blocker group compared to the non-beta-blocker group. If the trial is open, how was the randomization of patients to beta-blockers treatment ensued, rather than merely determining the usage? I understand that randomization based solely on coronary angiography and left ventricular ejection fraction is insufficient. Dr. Mandrola also refers to the clinical outcomes with beta-blockers for myocardial infarction meta-analysis of randomized trials published in the American Journal of Medicine, with a firm verdict. In contemporary practice, beta-blockers do not reduce mortality in myocardial infarction. However, I must note that the study's methodology has issues. The authors did not adjust the data in the publications included in the study, which is critical due to the wide diversity of studies. In particular, significantly more studies were conducted in the pre-reperfusion era, and significantly fewer in the post-reperfusion era. When examining post-reperfusion studies feature-free in the article, it becomes apparent that the total number of patients in all studies was much lower than in the COMET, clopidogrel and metoprolol in myocardial infarction trial. In it, the total number of patients exceeded 45,000. In other studies, the total number was much lower. Thus, the conclusions in the article are primarily based on this study. However, if we look at another post-perfusion study, such as EMIT, esmolol myocardial ischemia trial, we find that esmolol shows promise in preventing perioperative myocardial ischemia and associated complications. Why did the topic excite me? The same REDUCE-SWEDEHEART trial was conducted on patients with acute myocardial infarction and preserved ejection fraction. But in our medical sphere, the conclusions begin to extend to beta-blockers after myocardial infarction in general. My particular opinion is that there is no basis to believe that beta-blockers will take a backseat in the post-reperfusion era. They are an excellent medications and need to be used correctly. If done so, the results will always meet expectations. Beta-blockers have successfully repelled many attacks, and they will repel this one too. Thanks for likes and sharing.